Occasionally, women will present with acute sigmoid diverticulitis, and the picture can be confusing with more common gynecologic entities. Colonic diverticulosis affects 10% of patients over the age of 45, and cases in women in their 30s are not unusual, however. The most common location is the sigmoid colon, and the patient will present with pain in the left lower quadrant of a mild to moderate nature, anorexia with or without nausea, diarrhea or constipation, and a low-grade fever. Typically, the tenderness is in the left lower quadrant or suprapubic region. Occasionally, one can actually feel a palpable mass. Acute sigmoid diverticulitis may result in partial colonic obstruction due to the edema and spasm. Rarely, one may present with complete intestinal obstruction. Acute sigmoid diverticulitis may present with symptoms of partial colonic obstruction, but in a small percent of patients, complete colonic obstruction may be present. Perforation of the inflamed diverticulum may occur with local inflammation and pericolic abscess. Fistulae to the bladder or urinary symptoms are actually less common in women with uteri. Free perforation leading to free air outside the sigmoid mesocolon is rare. We're all familiar with the appearance of sigmoid diverticulitis on CT. We notice here that there are multiple diverticula, and there's bowel wall thickening as well as haziness of the pericolonic fat. And these are classic findings of sigmoid diverticulitis on CT. The diagnosis is usually straightforward. But the woman may present with symptoms that are somewhat atypical and may end up having an ultrasound first. The diagnosis of acute sigmoid diverticulitis can also be made using pelvic sonography, and that is important when the patient is younger or when acute sigmoid diverticulitis is in fact not suspected. The transvaginal sonogram is helpful when the inflamed sigmoid colon is located deep in the pelvis. We may be able to see a long segment of thick colonic wall and a prominent outer hypoechoic muscularis propria. That is the sonographic equivalent of the thickened sigmoid wall on CT. Now, the inflamed diverticulum is seen as a bright echogenic focus with shadowing, projecting beyond the margins of the thick colon. Of course, the pericolonic fat will be hyperechogenic and is a reflection of inflammation on ultrasound. And here is an example of the sigmoid colon with a thickened muscularis propria. And here is the sigmoid diverticulum with an echogenic focus of gas and dirty shadowing. This patient presented further in her course, and we see that she has a thick-walled sigmoid colon. Notice that the anterior wall is thicker, and there's a bilocular abscess contiguous with the colon and markedly echogenic pelvic fat. You see in this example how transvaginal sonography can be an indispensable tool in guiding drainage of these abscesses. Crohn's disease is a chronic transmural inflammatory process that can involve any part of the gut. Typically, patients present between the age of 20 and 40 and have multiple remissions and exacerbations. The small intestine is involved in 80% of the cases, most commonly the terminal ileum. And of course, most patients do not present with acute pelvic pain, but rather with chronic diarrhea, chronic pain, weight loss, and fever. Adherent bowel loops can form masses, fistulae, obstruction, perforation, and abscess. However, 1/3 of patients with ileocecal Crohn's actually present with their initial presentation is so acute that it mimics other causes of acute abdominal and pelvic pain, and it may mimic acute appendicitis and pelvic inflammatory disease. In the acute presentation of Crohn's disease, ultrasound may be performed to evaluate lower abdominal and pelvic pain. The ultrasound findings include transmural bowel wall thickening, again, prominent echogenic submucosal layer of the bowel wall, and hyperechogenic fat surrounding the bowel wall, which reflects mesenteric inflammation. We may also see enlarged mesenteric lymph nodes. Ultrasound can be useful to distinguish between phlegmon versus a well-defined drainable abscess. And again, transvaginal sonography can be effective when the involved segment of bowel is in the true pelvis and to guide transvaginal drainage of any interloop abscess. This is an example of the transmural bowel wall thickening seen in Crohn's disease involving the pelvic ileum. Notice the prominent echogenic submucosal layer and the loss of normal bowel wall signature. This is the same patient, a 32-year-old woman with a history of Crohn's disease. Her prior CT showed findings of ileocecal Crohn's disease here with bowel wall thickening and stranding of the fat of the iliomesenteric, of the ileocolic mesentery. 1 month later, she presented again with acute right lower quadrant pain and fever, and on transvaginal sonography we see thick edematous small bowel draped over this abscess. Again, notice that the surrounding pelvic fat is echogenic. Finally, the urinary tract may be the cause of acute pelvic symptoms. Patients frequently present with frequent urination, dysuria, hematuria, lower abdominal and pelvic pain. Pyuria may be noticed on the urinalysis, and imaging is usually unnecessary in acute urinary tract infection. In young women, ultrasound rather than CT is recommended as the initial evaluation in patients with increased risk, such as those with diabetes or immunocompromised states or pregnancy. And what we're doing is to look to assess for calculi, diverticuli, bladder wall thickening, debris, any post-void residual, and rarely tumors. What is the technique for assessing the urinary tract? The bladder evaluation with transvaginal sonography requires a small to moderate amount of urine. The angled vaginal probe should be looking anteriorly. The probe should be partially withdrawn to evaluate the bladder base and the urethra. Keep in mind that an over-distended bladder may obscure the trigone and actually obscure the distal ureters and the ureterovesical junction. It's important to recognize that the intramural and distal ureter are located slightly anterior and lateral to the upper vagina. So the dilated ureter is seen as an elongated tubular structure entering the bladder in an oblique course. Calculi in the ureter presents with typical renal colic, and it's important to realize that urinalysis initially may be negative if the ureter is completely obstructed. Later on, we may see large numbers of red cells and crystals. So distal ureteral calculi may present with pelvic pain and be recognized on pelvic sonography if we know where to look for them. In obese and pregnant patients and those with contrast contraindications, transvaginal sonography is helpful to locate distal ureteral calculi. In this example, this woman actually had a CT scan first, and this calculus was missed on the CT scan. But here you see on the sagittal transvaginal sonogram, we see the urinary bladder, and we see the somewhat dilated ureter and the shadowing calculus. In the transverse plane, we have the uterus, and we have the calculus in the distal right ureter to the right of the uterus. What is the significance of a negative pelvic ultrasound in acute pelvic pain? A study by Harris et al. Showed that pelvic pain improved or resolved in 77% of 86 women. So in a woman with acute pelvic pain, a negative pelvic sonogram is extremely useful because it has an excellent positive predictive value for resolution. To conclude, acute pelvic pain is one of the most common acute presentations in the emergency room, and in women, gynecologic, Genitourinary and GI etiologies may mimic each other. In our current working environment, definitive diagnosis is expected while the patient is in the ER. The use of pelvic sonography, including transvaginal sonography, should be maximized and used to its full capacity in order to limit the use of CT. Thank you.